All right, good afternoon, everyone. It's 12 o'clock. We'll go ahead and get started. Thank you all for coming today. It's great to see folks from quality, from the hospital, and some of our subspecialty divisions here as well. I would say thank you for coming on a very cold and frigid day, but I'm going to say the speaker today probably brought that with him from Michigan, so you can thank him later as well. A reminder that February 19th, we host Martin Casapia from the National University of the Amazon in Lima, Peru. Dr. Casapia is here as part of our Global Health Program speaker series, and we'll be talking about re-emerging arboviruses, clinical and pathophysiological updates on dengue and Urupuche viruses, so a very timely topic. And February 26th, on behalf of the Division of Renal Diseases and Hypertension, we'll welcome Dr. Catherine Tuttle from the University of Washington, and she will be delivering the annual Wallstrom Lecture in 2025. So today, I am glad to introduce to you my colleague and friend, Dr. Scott Flanders. Dr. Flanders is professor of medicine with tenure in the Division of Hospital Medicine at the University of Michigan. He earned his medical degree from the University of Chicago Pritzker School of Medicine in 1993. He then completed his medicine residency and served as a chief resident at the University of California, San Francisco, where he ultimately joined the faculty, rose through the ranks, and then was recruited to the University of Michigan in 2003. A personal story about Scott. Scott was responsible for recruiting me to the University of Michigan in 2007. He has served as one of my main mentors in hospital medicine. At the time, Scott was the chief of the hospital medicine program. It was a program within general medicine, which grew from a handful of faculty to several hundred people and became a standalone division in 2017 when I was selected to serve as the inaugural chief of the Division of Hospital Medicine. Scott used to always joke with me when he said one day I would be his boss. That day came in 2017, and it actually came because of his sponsorship and support. So I'm very happy to have you here today, Scott. Thanks for joining us. So Scott currently serves as the Chief Clinical Strategy Officer for the University of Michigan's Health System. He holds the position of Vice Chair of External Relations in the Department of Internal Medicine at the University of Michigan Medical School. In this role, he is the outward-facing leader for all programs and interactions of the Department of Medicine with external stakeholders. This includes such things as mergers, acquisitions, building clinical outreach, and developing the model of growth for clinical activities for Michigan medicine. I could tell you a lot about Scott, but throughout his career, he's been a pioneer in the field of hospital medicine, patient safety, and quality. He was a founding member of the board of directors for the Society of Hospital Medicine. He served as president of the society from 2009 and 2010. And perhaps through his years at SHM and as a hospitalist, Scott realized that hospital medicine providers, as inpatient providers, have a unique insight into how care is delivered in the building that we call the hospital, but also importantly, how it could be improved. So in 2012, Scott came up with this idea of developing a quality improvement platform that actually harnessed the know-how of hospitalists with hospitals across the state of Michigan. Now, these are hospitals that compete with each other for patients. So a novel idea. He was then able to convince an insurance company, Blue Cross Blue Shield of Michigan, that it was actually better to pay to prevent complications than to have to pay to treat them. He conceived and launched what you'll hear today, which is the Michigan Hospital Medicine Safety Consortium. And these efforts have subsequently informed patient safety nationally and internationally. For example, through work from this collaborative, the concept of risk stratifying patients at risk of VTE among medicine services was first explored. It led to de-implementation of VTE prophylaxis as we began to think about harms from that practice. And more recent efforts have included things like antimicrobial use, management of sepsis, and the appropriate use of vascular catheters. All of this work has informed guidelines, has informed clinical care, many of the things we do here, and importantly is now part of pay for performance and quality metrics in the US. What you'll hear today also is that this is truly a win-win-win across all missions. What is remarkable about the work is that it has led to substantial scholarship and extramural funding. Scott himself has authored over 200 peer-reviewed publications. He's received numerous awards for his work in clinical leadership and quality, and has actually been continuously funded for this work from Blue Cross Blue Shield for now almost 15 years, 14 years. I'm grateful to see many leaders from our department and our hospital here today. I wanted them to hear as we think about this idea of thinking about quality not only in our system, but also beyond. And I'm hoping that this model can inform how we think about our initiatives here at the University of Colorado Anschutz. So please join me in welcoming Scott for his grand rounds today.
Thank you very much, Vineet. Let me make sure you can all hear me all right. Thank you for that wonderful introduction, Vineet. And, Vineet mentioned that he's been a mentee of mine. I will say he is a mentor also for me. And it reminds me of a statement my chair of medicine at UCSF, Dr. Lee Goldman, once said is, be kind to your trainees and the people you hire, because one day you may actually work for them, which actually ended up being true when Vineet became my division chief. So I'm thrilled to be here with all of you today. It's been a wonderful visit, great meeting a lot of people, hearing about what you're doing, an amazing group of individuals and talent you have here. Really, it's been exciting for me. But we have been on as Vineet mentioned, a 15-year journey in the state of Michigan, trying to improve the quality of hospital care in our state. And I'm thrilled to be here to share a little bit of that journey with you today. This is where we're going. I'm going to start a little bit with what this infrastructure is we built. It's called the Michigan Hospital Medicine Safety Consortium, or HMS. Talk about what we're focusing on, what some of our current initiatives are, and hope I can convince you that we've made progress and we've had some success, but then spend a bulk of my time explaining why we think we've been successful, what's been the secret sauce of driving multi-hospital quality improvement. And then I'll end with a little bit of where we're going next. So I will start first with a case, as I was instructed to do. This is a case from a hospital in our collaborative, 250-bed hospital, northern part of our state. And the case involves a 63-year-old woman who presented with fatigue, myalgias, nausea, vomiting, diffuse abdominal pain, and subjective fevers. In the emergency room, she was afebrile. She had a respiratory rate of 31, her initial blood pressure 106/54. Subsequent blood pressure an hour later, 81/48, she had 93% on room air was her saturation. She did not have a leukocytosis, but did have an elevated creatinine over her baseline and a lactate of 2.0. And a very abbreviated hospital course was that she was ultimately diagnosed with sepsis. She did receive IV fluids, did receive broad spectrum antibiotics, but unfortunately deteriorated, required transfer to the ICU, and ultimately died on hospital day 5. This case, as a result of the death, was flagged at the local hospital for their quality team to review. And one of the conclusions was, per the national CMS sepsis measures, in particular the SEP1 3-hour bundle, the hospital had passed all those success, including the lactate, fluids, blood cultures prior to antibiotics, and broad spectrum antimicrobials. So they suggested it was a bad outcome, but there was limited opportunity to improve. That was the hospital review. This case was also abstracted for our registry and allowed us to do a bit of a deeper dive. And I'll come back to what we found toward the end of the talk. But let me start with what I'm talking about today. What is HMS? It is something we call a collaborative quality initiative, or a CQI. There are 24 of these now in the state of Michigan. As Vineet said, this launched around 2005 with an initial focus on cardiac catheterization. And groups of hospitals and providers came together and were quite successful in reducing rates of contrast nephropathy by working together, reducing contrast dye utilization, and as a result began to roll it out into other specialties, many shown here, largely procedural. We came along in 2010 and said, you ought to try thinking about this with hospitalists, hospital medicine focused on the hospital medical patient, and convinced them to launch a collaborative quality initiative in 2010. So 15 years ago is when we started this. And our broad mission at HMS is essentially to partner with hospitals and doctors to improve the quality of hospital-based medical care. We work with a lot of hospitals. You see it on the right, 69 hospitals across our state, everything from big academic medical centers to small, rural, critical access hospitals. We have 2 of everything, we like to say. And the coordinating center for HMS is housed at the University of Michigan. And at a high level, we basically create data registries, measure performance, understand who's doing what well, leveraging positive deviance, and try to figure out how to translate those lessons to other hospitals to elevate care for everybody. Perhaps overly simplistic, but that's our goal. And it takes a village to do this work. The picture in the middle shows our coordinated center team. We have almost 30 team members, and that includes a lot of physicians for whom we support fractional effort, but also includes full-time staff. We have PhD statisticians, data analysts, We have several nurses with quality backgrounds that help train our abstractors. They help do QI work at our hospitals. And if you look closely, I think you can see Dr. Chopra peeking out from the back row up there from, I think this was maybe last summer. And on the right, you see the initiatives that we've worked on. And we essentially moved from initiative to initiative, creating a data registry, rolling out this work in each of these, either focusing on prevention of an adverse event like VTE, as Vineet mentioned, improving the safety of a device, intravenous catheters, PICC lines, a drug, antibiotics in this case, or focus on a diagnosis or condition. COVID during the pandemic was a big initiative of ours, and more recently focusing on patients with sepsis, trying to improve their outcomes. So that is a whirlwind of what HMS is and the work that we're doing. I'm going to back up a little bit and say, what is the problem we're actually trying to solve as a quality collaborative? And at a high level, it's trying to improve the care of hospitalized patients. And this has been not just a journey for us, but this has been a multi-decade journey for a lot of us as we think about hospital-based quality. And we can debate when this actually started. For me, a pivotal initial point was the publication of the Institute of Medicine to Errors Human Report, which was really the first time they tried to shine a bright light on adverse events, in particular errors, safety events, wherein they estimated over 100,000 patients each year die as a result of errors or mistakes in the hospital. Importantly, they argued that the solution to that is redesigning the systems that are delivering those errors rather than a punitive provider-based approach. That report was quickly followed by another IOM report, Crossing the Quality Chasm, which identified a big gap between ideal performance, current performance in hospital-based care. And this publication argued for investment in infrastructure to support quality improvement, pay for performance models, transparency around public reporting and performance in hospitals. And this all came out at a time many of us, and I see Dr. Glasheen in the audience, were entering our careers in hospital medicine. And hospitalists became a key partner for hospitals trying to improve the quality of care. And so we got immersed in this. And I would like to argue that over several decades, we've made progress. The publication you see here in the middle of this slide is an interesting article in JAMA from Harlan Krumholtz and his group, essentially looking over a pivotal decade, 2010 to 2019. And they reported that over that interval, we made significant declines in adverse events, predominantly focused on some of those conditions we focused most on in public reporting, pay for performance, pneumonia, heart failure, surgical adverse events. So clearly progress. The paper on the far right of this slide was a bit of a humbling, sober publication, came from David Bates and his group at Harvard, that did detailed medical abstraction across 11 hospitals in Massachusetts and reported, this is about a year and a half ago, that they still felt that about 1 in 4 patients in the hospital suffer an adverse event. And while many of those are not preventable, over a quarter were felt to be preventable. So progress, but we still have a lot of work to do. And trying to solve this problem feels a little bit like boiling the ocean. And so for us in HMS, we've had to break it down to the problems we feel we can actually solve. And for the most part, our approach to thinking about that, what we should focus on is what's important to Michigan hospitals, top of mind. Whatever we're focusing on has to involve a lot of patients. There has to be a demonstrable gap between ideal care and current care. And a more practical need for us is we need physician expertise to lead, drive this work, and improve care in the hospitals. And that was all true with the case of peripherally inserted central catheters or PICC lines in work led by your department chair, Dr. Chopra, where back in, I think this was 2012, Vineet, if I'm remembering correctly, Vineet was probably one of the first to shine a bright light on the problems we were seeing in hospitals, which we had seen in Michigan hospitals. PICC lines were used very frequently. A lot of patients received them. Huge variation in use, which may not be problematic unless they're associated with a lot of complications, which they were. Venous thromboembolism or VTE, CLABSI or central line associated bloodstream infections or mechanical complications. And when those occurred, catheters got replaced, which further increased risk of VTE and infections. So this was an area that we felt we could do a deep dive and work on. Similarly, antibiotic use in US hospitals. The CDC has said over half, I think, of medical patients receive antibiotics at some point during their hospitalization. More concerning is about half of those patients have an opportunity to do a little bit better. Big common buckets being overly broad antibiotic regimens, treatment for too long being most common. And in work led by Valerie Vaughn, who was a hospitalist at Michigan when we started this work, a mentee of Vineet and mine, along with Tejal Gandhi, who is an infectious disease doc and heads our stewardship program at Michigan, published a paper highlighting what we saw in Michigan was that when we looked at uncomplicated community-acquired pneumonia patients, over 2/3, 68%, were treated for too long, excess therapy. And that excess therapy was associated with more antibiotic-related adverse events. So an important problem affects a lot of patients. We had some expertise to do a deep dive around this. And similarly, sepsis. This was a review article from the New England Journal a couple of months ago, I believe, by Dr. Hallie Prescott, who is a sepsis researcher, international expert at the University of Michigan. I think she was here giving grand rounds this past summer. And so Hallie authored this article in the New England Journal, highlighting a lot of what you already know. Sepsis is pretty common. I suspect you're focusing on improving your outcomes related to sepsis as we are. High mortality, up to half of hospital deaths are felt to have some component of relation to sepsis. And even if someone survives that hospitalization, there's huge amounts of morbidity, functional decline, cognitive decline, poor ability to return to work, financial distress, and there are gaps in care that are pretty common. So another area, we have the expertise, it's an important problem, we're gonna tackle it. So those three initiatives right now are the core of the work that we're doing within HMS. And each one of those initiatives has a set of performance goals that are linked to the outcome we're trying to improve, and we drive our hospitals toward achieving those performance goals. And I won't go through all these, but I'll take pick. The performance goals there were, we need to reduce short-term use less than 5 days, because there's a safer device if you're gonna only need this for 5 days. Minimize multi-lumen. More lumens means more clots, more infections, more mechanical complications. Reduce use in patients with CKD, because that damages veins. Those patients may need those veins for vascular access ultimately if they progress to end-stage renal disease. And then we're focusing on a particularly challenging group of patients, critically ill patients and oncology patients, for whom multi-lumen devices are quite common, and it's a bit more challenging to figure out how you minimize multi-lumen devices, but doing a deep dive there. And for every one of our initiatives, we have a tiered quality improvement strategy and a toolkit that supports this work, and I'll come back to what those look like a little bit later. And I will make an argument, without going into a lot of detail here, that we have been successful using that strategy to drive performance. This is just a screenshot that we shared at one of our meetings a while ago, looking at the progress we've made on our process measures for PICS. So we started first with saying you got to document indication. When we started this work, no one documented indication. Over time, we got it close to 100%, and importantly, appropriate indications went up dramatically. That led to significant increased use of single lumen, which was the desired trend, significant reductions in short-term use, and declines in patients with CKD. So our process measures were all moving in the right direction. What's more important is that the key outcomes and complications went in the right direction. And in work that Vineet was the first author on and published in BMJ and Quality and Safety, looking at a subset of our hospitals, 52 of them, demonstrated significant reductions in major complications. Mechanical complications declined, VTE declined, and CLABSI declined significantly over time. So driving to the process measures led to important reductions in outcomes that are important to our patients. And that's not just true of our PIC initiative. We see the same thing with respect to our pneumonia work. This shows appropriate 5-day treatment, percentage of patients that got appropriate treatment across our collaborative over time. And it's amazing how horrible this was when we started. We've seen almost a 200% relative increase and 40% absolute increase in appropriate treatment for patients with community-acquired pneumonia. And we also focus on improving treatment of urinary tract infections in hospitalized patients, reducing treatment for asymptomatic bacteriuria. And across all those initiatives, hundreds of thousands of days of antimicrobials saved just in our sample population over a subset of our hospitals. So we've also seen adverse events go down with respect to adverse events from antimicrobials. So progress across those initiatives. And we don't just focus on the quality piece. We're looking at the entire part of the value equation, which is quality and cost. And so we want to improve the value of care and drive down costs. This was a cost effectiveness article that was led by Megan Heath, who's one of our PhD statisticians, looking at the value that our PIC project delivered. And what was shown here over a 7-year period in a subset of our hospitals was we reduced thousands of blood clots, thousands of occlusions, and central line associated bloodstream infections. And because those are so costly, that's a significant cost savings. And we estimated over 60 million saved over a 7-year period over 35 hospitals. And that scales to an even larger number across all of our hospitals. And it scales to populations we haven't looked at and haven't sampled, where these practices tend to be hospital-wide, not just focused on our sample. And even when you take into the amount of money that gets invested in doing this work, it ends up being net cost savings. So there's value added, not just from the improved outcomes, but from reduced costs of healthcare. And our mission is also focused on disseminating this work and generation of new knowledge. We want what we're doing not just to inform care in the state of Michigan and our hospitals, but to leave our state and affect care everywhere. And we largely do that through publications in the peer-reviewed literature. This is a slide we showed at our executive steering committee meeting about a month and a half ago, and shows just the publications across each of our initiatives in the last year. And I hope you'll appreciate that these are fairly impactful journals in each of these fields. And so to me, that argues the work that we're doing is generalizable. It's relevant to hospitals in other parts of the country, and it's worth thinking about how you might implement or move in the direction and take those learnings and apply them elsewhere. So this is another way I think we try to have impact with the work we're doing within HMS. So that was a whirlwind of who we are, what we're doing, and what we've accomplished. And without going into a lot of detail, I hope I convince you we are making progress. We're making a difference in the care of patients, improving the value, cost, quality of care. I want to spend most of the time now focusing on how do we do this? Like, what actually is the secret sauce to helping these hospitals improve this way? And I will start first with what does the literature say is necessary for a hospital to improve its performance. And there's been a lot of work in this space. This was a pretty high impact article. It's a systematic review, 20 different studies, looking at what are those characteristics of hospitals that are top performers, are actually able to improve compared to those that do not. And maybe some of these are not so surprising on the left. When you look at these high performing hospitals that get better over time, they tend to have positive organizational culture, leadership that's bought in, driving this work forward. They often have infrastructure to support quality improvement work. They've got the training, they have expertise-driven practice, and importantly, multidisciplinary, interdisciplinary work are key components. And so if we're thinking about trying to do this in a bunch of hospitals across Michigan, you either have to have the hospitals have this or you have to bring it to them. And we've focused a bit more on the latter, trying to provide as much of this as we can to make sure hospitals are well positioned to succeed. And I would say one of the more impactful things we bring is the infrastructure to drive this work. This is actually a screenshot of a data definitions dictionary for a subset of one of our projects. And I would say our granular clinical data is the most important part of all of this. And I show this to let you know that there's a lot of detail that goes into this data abstraction. We have trained abstractors at every one of our hospitals. We audit our hospitals on a regular basis. And that allows us to give very, very granular apples to apples comparisons, detail to our hospitals. This is an example of a report for one of our initiatives around sepsis that we give to a hospital, where our reports will show the hospital's performance, which you see in that orange bar in the upper left, compared to regional hospitals near them. We track their performance over time. We give them outliers, cases that have fallen out, so they can go do a root cause analysis as to why the patient failed the measure, to understand what their opportunities are. And we always include our definitions, because our teams take these reports and deliver them to hospital leadership, their quality teams back at the hospital, and they often ask all these questions. So we give it to them in these reports. They can get online, download these reports, generate them anytime they want, and they use them often. That granular data allows us to do apples to apples comparison. In every initiative we've ever done, if we look across all our hospitals, there's huge variability, disturbing variability in some situations. This is an example looking at observed to expected risk-adjusted mortality for sepsis across all of our hospitals. Each orange bar is a hospital, and you see the huge variability. But you also see to the left of this curve a cluster of hospitals that are achieving really impressive, observed to expected sepsis mortality less than 1. And so what we do is we look for that and then go and find, look, see, identify what are these hospitals doing. I don't have time to do it justice, but when you go look, they are doing different things. They have a vision of what they're trying to drive forward. They have metrics that they're marching toward. They have things like sepsis rapid response teams, nurse-driven initiation of treatment protocols, very different from the hospitals to the right. So our job is to try and take what they're doing and figure out how you adapt that in a way that other hospitals can implement, drive that same type of change, and the goal of elevating. Same thing with respect to our antimicrobial work. This shows each blue bar is a unique hospital. It shows the percentage of their patients that get appropriate 5-day treatment. And you see some hospitals like never do this. And then you see hospitals on the left that do this consistently. Same thing. You go and look, they are doing very different things. They're focused on this. They have goals. They're not meeting them. They change their tactics. They have stewardship teams that are engaged. And even those that don't have formal stewardship programs, they have individuals that are looking at high-risk moments like the discharge. And so we can learn from that and say, if you're going to have success, if you're a hospital to the right, here's the type of things you need to implement. We help them do that. The other thing I think that we have tried to do more recently is leverage competition. And we do not allow competition for the sake of marketing. Hospitals are not allowed to share this publicly and say, hey, we're doing better than Hospital X, look at our HMS data. They sign agreements at every meeting to say they're not going to share it outside the meeting, but we do leverage internal healthy competition. We used to just compare each hospital to a state average. Wasn't that impactful? Then we said, how about we compare rural, urban? Not that impactful. When we asked our hospitals, they said, how about our regional competitors? They're often competing with the hospital 20 miles, 15 miles down the road. So we divvied up our state into regions, and that's been more impactful. And my project manager said we should have known that coming from the University of Michigan, because look at our football team. As the Big Ten has expanded, the coach loses to Oregon. It's like, lose to Michigan State, get fired. And so that team, that organization that's right up the street is the one you often pay a lot of attention to, even if the national landscape is saying, no, you should focus more on Oregon. That's not the way it works. So we leverage this regional competition, and it works. We also create a venue for all these groups to come together, share what they've learned, share our progress, which we do in collaborative meetings. Every one of these is a full day event. We have workshops where they break out into groups, do deep dives on these process measures, troubleshoot, ask other hospitals how they did things. They're powerful, powerful gatherings. And we do webinars outside of these collaborative meetings to keep that engagement going. And the multidisciplinary teams are key to this. I referenced the literature that suggested interdisciplinary teamwork, multidisciplinary teams are key to top performing hospitals. And we realized early on, we started this work focused on hospitalists. We said, if we're going to do hospitalized medical care, you need the hospitalists. That's where we started. As we moved into, I'll take Vineet's project, PICC lines, you can't change the way PICC lines are delivered unless you're working with the nurses, the vascular access teams, interventional radiologists. If you're going to reduce use in patients with CKD, the hospitals would say, like, well, do the nephrologists agree that we should use this device or not? And so we had to bring those teams into our collaborative, and we've done that across all of our initiatives. And now with just 69 hospitals, our meetings have these multidisciplinary teams. There's over 400 people that come to each of our meetings. So it takes a big village, and it takes multidisciplinary work to change the way we deliver care in the hospital. And we try to create a venue that facilitates that. And we go look and see. For those of you in quality that understand like the Toyota lean production model, where it's called going to Gemba, where you actually go watch, look, see a product being made. We do site visits where we bring our experts and they follow a patient from the emergency room all the way through, kind of like the Joint Commission does their tracer methodology. And you learn a lot when you have an expert looking at how they intake a patient, what their order sheet looks like, how they discharge a patient. It's very powerful. Unfortunately, these are very time consuming and we've got a big state. And so there's often more demand than we have the capacity to go do these. But we've tried to divide and conquer, and you'll be amazed at how many of these 69 hospitals we've actually set foot in to do some of these site visits. Very impactful. And I mentioned our toolkits. This is a series of screenshots of our toolkit from our antimicrobial project. We actually partnered with the CDC, and I'll come back to our partnerships, to develop this toolkit. We shared with them, they shared with us. And it's not just, here's some tools to use. We actually take our hospitals through a tiered approach to driving improvement. So You're not supposed to read this, but it has directions that if you are going to tackle appropriate 5-day treatment for uncomplicated community-acquired pneumonia, you first need to pull together a group, and here's the people you need in the group. You then say, for this measure, there are 13 steps up here that you need to work through step by step that we have learned lead to success. And so start at the top and work your way down. We do have links to order sets, laminated pocket cards, national guidelines, peer-reviewed literature to support a lot of those recommendations that drive this work. But this is critical to our model and the success. And I will also say, if we look and the national guidelines don't exist, we need to create them, as Dr. Chopra did in this work here. When we started our PIC work and we saw huge variability in use, the quick question was like, well, what's the right way we should be using those devices? Like, what do the guidelines say? Well, there really weren't any. There weren't good ones. And so with a multidisciplinary international group of experts in this space, with members from our collaborative, with people that had methodologic expertise in the UCLA RAND appropriateness, which was used in the 80s to figure out when was a cardiac catheterization appropriate. It's a well-defined methodology. Vineet led a group to develop what is now called the Michigan Appropriateness Guide for Intravenous Catheters, or MAGIC, which now has been disseminated nationally and internationally as the way we think about who should get a PIC line, who should get a midline. And out of that document came the key recommendations for our hospitals I already mentioned that we focus on and drive toward that are linked to the outcomes we're trying to prevent. So we can create these recommendations and guidelines if they don't already exist, as was the case here. And just as I mentioned with antimicrobial, to do the PIC work, it was the same tiered strategy. Very much of a hand-holding. Step one, create a vascular access committee. And you don't see it here, but it includes like who should be on that committee. Who are the key members you have to have if you're going to have an effective committee? And then step one is you need an appropriateness tool. We had MAGIC. They could use something else, but quickly realized there wasn't anything else. So all of our hospitals used that tool and then took them through a series of steps for each of the process measures. And the other unique thing we did here is we then divided hospitals into what was the biggest complication or problem they were having. Was VTE their biggest problem? Was CLABSI their biggest problem? Were mechanical complications? And based on where their data showed they were struggling, we drove them to an improvement strategy in that bucket. So very much of a hand-holding, directed approach to quality improvement, as opposed to here's the guideline, you need to implement it. Far more structured. And I mentioned our partnerships and extramural funding. This has been critical to enhance, drive, and accelerate our work. This slide shows all the different partnerships, the grants, the extramural funding agencies that have supported our work over time. And just taking antimicrobial, I mentioned the CDC, it's very impactful to pull out a toolkit that you ask the hospitals to implement and said it's basically co-developed with the CDC and endorsed. And go to their website, you'll see it right on the CDC's website. We've done work with a lot of other foundations. AHRQ is up here. Valerie Vaughn, who leads our antimicrobial stewardship work in our hospitals. She's now at the University of Utah. She had received R01 funding to use our collaborative to do a randomized trial. And we've randomized 50 of our hospitals to a tailored intervention to reduce inappropriate discharge prescribing of antibiotics, which is where the biggest problems are compared to usual care. And usual care is what we're doing anyway with an HMS. So we'll see if the added investment and effort to really do an even deeper dive leads to added benefit or not. So we use our extramural funding to further the impact of the infrastructure that we've created. And the same holds true for sepsis. And our work with the CDC around antimicrobial has led to an interest in working with us around sepsis. And the CDC funded Dr. Prescott and our HMS team to develop what's being called the core elements of hospital sepsis programs. So the CDC had done this for antimicrobial stewardship. What are the core elements of a stewardship program that every hospital should have? They worked with us to develop these for sepsis under Dr. Prescott's leadership. There's also a program assessment tool that we created. And I won't walk through each of these, but these are important structural things that if you're going to drive to high performance in caring for sepsis patients, you need many, if not all of these components in your program to drive improvement. And the important thing is we've actually shown in our collaborative that it's actually linked to the outcomes that we're most interested in. This is a table that I hope will be in a peer-reviewed publication over the next month. And it basically looks at quintiles of mortality within our sepsis registry. And what you see here is the top performing hospitals in the highest quintile, quintile 1, had implemented 100% of the top 3 structural elements that we had developed with the CDC, compared to quintile 5, which was less than half. And perhaps more convincingly and importantly, when hospitals implement these structural elements where they didn't exist before, we see improvements in their performance with respect to some of the key process measures. So some of these structural elements do actually have an impact in the care that gets delivered. And I have to call out the fact that we do have a pay-for-performance model. Our hospitals are incentivized to perform well on all these performance measures. And I mentioned Harlan Krumholtz's article where he looked at our national experience over the last couple of decades or last decade. And he did find that those initiatives that were reflected in public reporting, pay for performance, tended to have the most change. And I will say we leverage the support we get from a payer to drive in the right direction. We score all of our hospitals. You're not meant to read this, but every hospital has a scorecard. They get 100 points. It includes everything from timeliness of data submission to data integrity, to their individual hospital performance in each of these measures. We have different thresholds of performance for different points, and the points make a difference in how much they pay or get paid. Here is an example of just one hospital year to year that improved from 75 or 73% up to 100% and what the difference in their payment was. And you can argue either way. This is a lot of money or it's not a lot of money. I will tell you, most of these hospitals participate in multiple CQIs. And I can tell you the University of Michigan, when we add this up, it's multi-millions of dollars. And so our quality leads take a look at all these different CQIs and say, oh, look, you're getting half of the points here, only 20% of the points here. If we raise that up, it makes a difference. I don't think this is the driving force. A lot of our hospitals are type A people. They want to get 100 on the test. But the dollars are there. And I do think at the margin, they will make a difference in how our hospitals improve and perform. And I can't talk about hospital-based quality improvement without talking about the electronic health record, or the EHR. It's just part of who we are and the way we do our work. This was a slide we showed at one of our recent meetings related to our antimicrobial work and the variety of different strategies and tactics in the EHRs, which have been used to drive the performance that you want. Defaults are used commonly, where when you click on something, what you're supposed to do is pre-checked. You have to uncheck it if you don't want to do it, commonly used. Manipulating availability, not having a drug in an order set that you don't want docs to use, certainly as first line. Changing the order, you have the generic listed first or the one you want first. So the first one the doc goes to when they're moving quickly and clicking, as you know we all are, you click on that first one. Giving a result context called framing. The one example from antimicrobial we have is when micro gives you an organism and then has a little text that says these organisms are most likely contaminants. That reassures a doc, especially when it's like a name you haven't heard of before, since they're changing the name of all these organisms, by the way. You take what was that called a year ago? It has a new name to it. And it's very helpful if your lab says, by the way, a majority of these are contaminants. Manipulating workload. If you don't want someone to do something, just add 3 clicks and they won't do it. That's very effective. Hospital administration has figured that out as well. Removing triggers, a very controversial example. There was a hospital in Toronto that hid all their urine culture results. And they reported this in BMJ Quality and Safety. They essentially had a little note there that said a majority of urine cultures in hospitalized patients represent asymptomatic bacteria, which does not warrant antibiotic treatment. If you feel otherwise, give us a call. We'll give you the culture result. Turns out nobody called. And they saw dramatic declines in use of antimicrobials for these urine cultures, and apparently reported they did not see a signal with any adverse outcomes or complications related to that. And I'm not saying our strategy is to hide everything from the providers, but it's a somewhat controversial but interesting example of the power of how you present information to providers makes a difference in what they do. One compelling example we have from our work with antimicrobials came from that same paper I referenced before with Dr. Vaughn, where she showed that over 2/3 of patients were treated too long. Turns out all of the excess use happens at the time of discharge. 93% of it happens. Because if treatment's 5 days, we all know the length of stay for an uncomplicated pneumonia has been lowering and lowering and lowering. It's almost always less than 5 days if it's truly uncomplicated pneumonia. So this was a table from the appendix of that paper where the top part of this shows what we think the expected duration should have been. So the most common thing we should have seen is nothing at discharge. They completed their course in the hospital. The bottom shows what patients actually got. And there were significant signals at 5, 7, and 10 days. And why do you think that was? When you go to the EHR, the boxes you can check on discharge are 5, 7, and 10 days, or you can type in a duration. And so docs tended to click one of those boxes. And we saw this at multiple hospitals. So this is an example of a problem where if you're going to change the way things are happening, the solution is going to sit within the EHR most likely. So we've needed to leverage the EHR. And we've gone so far. I show this. This is a screenshot of our seating map from our last collaborative meeting. All those circles are tables with people sitting around them. And for our workshop, we realized we had to break people into groups that had the same EHR. For them to share strategies, it was almost always an EHR-based strategy to drive some of these performance measures. Not always, but often. And so this was the Epic table, the Cerner table, the Meditech, and there was a really sad little group called Other that was in a different room, just longing to be in the Epic group, who were doing a lot of sharing back and forth and strategies to drive in the right direction. So the EHR is critical to our work, and we are constantly working on ways to figure out how we do a better job of allowing things to be shared, because there are some big structural barriers to doing that routinely. But this was a first step for us in thinking about how you recognize and leverage it to drive improvement. And I will say the last, bucket of work that we have focused on and tried to leverage is this principle of what I call systemness. You may appreciate, if you don't, it is happening out there nationally. Hospitals are consolidating. Multiple hospitals, individual hospitals coming together in multi-hospital systems merging together into multi-state large systems. We see that playing out everywhere. This graph shows that phenomenon in our state of Michigan. And what you see here compared to 1990, where 62% of our hospitals in Michigan were independent hospitals, only 38% were part of any system that was more than one hospital. Fast forward to 2024, it's only 15% of hospitals that are independent. And most of those are small, little, rural, critical access hospitals. So it's the rare hospital that doesn't have a partner hospital or several other hospitals as part of this system. What is a more interesting question is this a good thing or is this a bad thing? Many hospitals argue we're doing this to find economies of scale. We're doing this to elevate care in some of these hospitals that struggle with the resources. We saw this play out in COVID for sure. They build programs, build capabilities. So the hospital systems say we're delivering higher quality of care by partnering with these hospitals, acquiring them, consolidating, integrating. There's the other side of that argument, the skeptics who say you're only doing this to increase your leverage with payers. You're trying to get more money by having greater scale to be able to argue for higher rates from the insurers. And the interesting thing is when you try to do a deep dive and say, well, let's actually evaluate this and see whether or not consolidation of these systems make a difference. It has been hard to show that it leads to better quality. And in fact, this was an article that got a lot of attention from the antitrust people in Washington, D.C. and others that looked at changes in quality after mergers and acquisition. It was 2020, New England Journal of Medicine, and they looked nationwide, used Medicare claims data, and they essentially looked at what was the change in performance of these hospitals that were acquired, integrated into a multi-hospital system, versus not. And they matched to like hospitals, looked at trends over time. And what they actually found was there was no significant increase in some of the most important outcomes, mortality, readmissions. What they found were significant declines in patient experience scores. And the authors argued, proves what their theory was this is not driving better quality. They sort of argued, now you have more leverage with payers, you don't have to pay as much attention to quality, which I think is a very negative glass half empty approach to this. I think differently. Part of my day job is working on consolidation across our state for our health system, and I happen to be convinced we're making a difference. But there is an interesting literature. The paper on the right is from our chair of surgery at Michigan, Justin Dimmick, who does a lot of work with surgical quality as a health services researcher in surgery. He looks at hospital systems, the impact on quality. And he's done a lot of work that when hospitals think regionally, come together and collaborate around surgical care for cancer patients, doing things like consolidating high-risk surgeries in one institution, sharing approaches and guidelines for that non-high-risk surgery across the system. Those systems that do that have shown significant declines in mortality for cancer surgeries. So if you think regionally, you may have an impact. And so we have taken that principle to heart and tried to do that within our hospital. We noticed early on, there would be 8 hospitals, as you see on this graph on the left, in our collaborative, all who had the same name on that building. But you would see one being a top performer in a particular initiative, and you'd see one at the bottom end of the scale. And you'd scratch your head and like, they're the same. Like, how is it that these teams don't know each other, work together? Why could you have such variability? And so we tried to see if we could solve for that. So we began to group our hospitals in the system together to do some of these workshops. We brought in the CEOs, the chief quality officers, the chief clinical officers to show them the data, to begin to troubleshoot with them what's a way to solve this problem. And we've started to make some progress. This is basically a before and after this 8-hospital system where the chief clinical officer decided to standardize their approach to sepsis across the state. Each hospital had their own approach, different committees, different teams working on it. She standardized it across the state, utilized a lot of our HMS metrics to drive in performance, which are very much aligned with the SEP1 measures. So if you're making progress on ours, you're making progress on the SEP1 measures, which obviously all these hospitals cared about. And what we've seen is the tail come up. We've seen improvement in some of those hospitals as they have aligned. And we've seen this in other systems as well. So we're going to continue on with this and see if we can't defy the odds, if you will, since the peer-reviewed literature says systems don't improve quality. We hope we can have a lot of different cases where we've leveraged this consolidation in systems to drive quality forward. So another way you can leverage the fact you work with a lot of hospitals around the state. And I will say it's not all good news. As much as I like to get up here and tell all the great things that have happened and the success stories, there are some failures. We have always noticed when you looked at variable performance across our initiative, there's a cluster of hospitals we say are to the right of the curve. Poor performance is always to the right on our graphs. And so that red arrow shows the same hospital that's toward the bottom for our antibiotic measures, and it's also at the bottom for observed expected sepsis mortality. I don't think they are directly linked. And there are a group of hospitals that find themselves to the right, if you will. And turns out, when you take a look at what is it about these hospitals, again, I'll go to Dr. Chopra and Valerie Vaughn, who did this work when she was at U of M, looking at organizations that struggle to improve quality. What is it about them? And they did a systematic review of a bunch of qualitative studies, and it was a variety of things. It's almost the inverse of that list I showed you before, what top performing hospitals do. So these hospitals tend to have a poor culture. They don't have the infrastructure to drive the work. They don't have mission, vision, a true focus on what they're trying to accomplish. System shocks are critically important. This is the financial catastrophe. This is the CEO that leads, or half of the workforce gets fired because of a financial crisis. They have dysfunctional external relations. They can't do multidisciplinary care. There's this reluctance to partner with anyone outside their organization. And I absolutely see that in that hospital with that red arrow, which will remain nameless. But I know which one that is, and there are others like it that have many of these things playing out. And the good thing for us out of all of this, if there's a glass half full, we know until some of those things are addressed, it's just not worth our time doing a site visit, doing a deep dive. Some of that stuff has to change. And so in some sense, that's allowed us to figure out, are there some hospitals that, I hate to say it, are not worth our time? And let's focus on the ones that are a little bit further to the left that have some of these things, but are just trying to figure out how they can get better. That's where we've focused over time. So I'll come back to our case, which I presented at the outset. If you'll remember, this is a 63-year-old woman who presented with fatigue, myalgias, nausea, vomiting, abdominal pain, and subjective fevers at home. So I showed you before what the hospital's look at this case was. This is what our look of this case was. So we have all the data. We know everything that happened to this patient from the moment she hit the door until the moment she died. And so we actually felt, in contrast to the hospital, that she presented with signs of potential infection. She had subjective fevers at home. I'll acknowledge she wasn't febrile when she hit the door. She had hypotension, pretty significant, at hour 2. She was tachypnic. She had a new renal dysfunction that was otherwise hard to explain, aside from some volume contraction, significantly higher than her baseline. The hospital, however, did not document concern for infection until day 2, which is when she was starting to decline. And so she got antibiotics right after they documented concern for infection. She got fluids right after they documented concern for infection. That was 31 hours after she showed up in the hospital. The SEP1 bundle, the national performance measures, require documentation of suspected infection and serious criteria, and that's when the clock starts, time 0. And so they had 3 hours to get everything done. Well, they did it in 3 hours, but it was actually 33 hours from our look at this. And so this was an example of a case that we said, you failed this measure. And they're like, what? But our team reviewed this and there were no quality issues. It's a good example about how we're able, even in something that's a focus of a national quality improvement initiative, we're able to go just a bit deeper and be able to show the hospitals that there's still opportunity to improve. And this was a great example of one of those cases. So again, hopefully a compelling patient story that shows on a patient level, the impact you can potentially have with some of this work. So I will leave you with where we're going next with our collaborative. And I will say we would love nothing more than to have this work move beyond the state of Michigan. Everyone always asks me, well, how do you do it there and how come it doesn't happen other places? I'm glad to answer that in more detail. But we have some opportunities. We've done some work with the state of Illinois and Blue Cross Blue Shield around a readmissions project. We are working with Dr. Chopra to see if this might be a model, whether it's vascular access or another initiative to implement here at the University of Colorado. We're developing an approach where our coordinating center will be able to support some of that work. Dr. Vaughn, who has now moved to the University of Utah, where she's a professor there, is working on rolling out our antimicrobial work throughout hospitals in Utah. And we have a great relationship with Duke and several organizations in North Carolina through our stewardship teams, where we're rolling out that stewardship project with them. So hopefully we're able to get some uptake and have this be a model that is perhaps generalizable from a structural perspective to drive multi-hospital quality improvement outside of just the state of Michigan. And we want to move into new areas. We move from initiative to initiative, and we are about to launch our next initiative, which is focused on the ICU. And some of you may be asked, why are a bunch of hospitals working on ICU care? We have long had an interest in looking at what happens in ICUs in the state of Michigan. This is a paper we authored, I want to say it was like 2009, back when there was a lot of movement on having, as a structural member, do you have a high intensity ICU staffing model or a closed ICU as a measure of quality? And we looked in the state of Michigan, and it was well less than half that were closed ICUs. And when we actually looked, most of those non-high intensity models had hospitalists delivering the ICU care in those hospitals, a variety of different structures. Fast forward to 2024, it's about the same. This is a slide from our sepsis registry showing who was the attending of record, which may be different from high intensity staffing models, I'll acknowledge, but who was the attending of record for the patient getting admitted to the ICU for sepsis across all of our hospitals. The blue is critical care, the yellow is hospitalist. And so you still see a majority of ICU patients are being cared for by hospitals in the state of Michigan. The hospitals to the left tend to be the large, big city, urban AMC hospitals. The one to the right tend to be the smaller that are spread throughout, where a lot of care in all of our states are delivered, these small rural hospitals. And I would say the time is opportune to work on ICU-based quality. We saw a major backside with COVID, with a lot of evidence-based practices in ICU care: proning, lung protective ventilation, light sedation, the ICU liberation bundles. The graph on the right shows declines in use of appropriate proning in patients that warrant that, which I'll acknowledge is a small subset of patients, but big backslide. And the good news is we know what works. We don't have to go develop the guidelines. We know that there are quality improvement tools like these A through F bundles, which addresses ventilator management, sedation holidays, delirium assessment, mobility. And we know that when you implement those, they work. We have an ability to look across our hospitals and say, how many are doing this, at what rate, where are the gaps? And we think we have a methodology that will drive improvement, which will improve all our patients that end up in the ICU, not just our sepsis patients. And we have opportunities to go into other areas in the ICU. Diagnostic error. we've worked on that with our antimicrobial registry around pneumonia and UTI. Like, what is not pneumonia and UTI? We have a lot of those cases. Well, it's something else that they didn't identify in that hospitalization. And we have some diagnostic error metrics. We'd love to do that in critically ill patients where the stakes are high. And palliative care, our sepsis registry has shown a very disappointingly low percentage of patients actually have goals of care conversations when they're critically ill in the ICU with sepsis. And I'm not just talking about a young, healthy person that spontaneously gets sick. We're talking about older patients, metastatic cancer, they're in the ICU with sepsis. You often do not see any conversation around end-of-life care, a big opportunity for improvement in our state. So we're going to tackle some of these things, and I hope over time I'm able to come back and show you the success we've had in the ICU and subsequent initiatives that we move on to. So that's our model. That's what we've been doing in our state, and would love to take questions, comments, critique, whatever you'd like to provide. But thank you for your attention.
Scott, thank you. That was great. We have a question right here from Dr. Badish. So you get us started.
Thank you. Great talk. Could AI be used to prevent the patient that you described from falling through the cracks? I mean, it seems fairly simple. Pre-admission fever, hypotension on the second blood pressure check, acute renal failure, you know, that patient ought to be flagged for having sepsis immediately. Then,
yeah, I think the short answer to that is yes. Obviously, we're early in that journey, and you know the precursor to AI has been those EPIC modules that flag sepsis patients. And there's actually a literature showing that there's some challenges with our current ability to flag patients, either with overly sensitive alerts that lead to alert fatigue for our doctors, or missed cases for subtle cases. So that's version 1.0. Whether AI leads to version 2.0, I have to imagine that's where we're going to go over time. But I think the answer is, I think it has potential. TBD. We are certainly not in a position to leverage that as of yet, but I hope that makes a difference for cases like that. It's a great thought.
So I really enjoyed the talk as well. It's inspiring. And as you know, Michigan's kind of been inspiring in this field for decades now, since the Keystone Project. And I want to ask two maybe big picture questions. One is about governance for this initiative. As you know, a typical learning health system will have 100 or more QI initiatives ongoing at any given time. How do you get 60 plus hospitals across the state to come to agreement that we're going to put the resources, right? It's hard to get the attention of the EPIC team. We're all going to do these three things. And then the second question, you used a term which can be a trigger word for some people, which is generalizability. You're publishing a lot. You're publishing a lot of QI work. What's your process for review of QI work? I'm sure you're familiar with the Keystone Initiative's history with, shall we say, conflation or blending of QI and research.
Yeah, a lot of questions, with a lot of great questions. So I'll see if I can remember them. Starting with that last one, we are at that intersection of QI and research for sure. So we do have a rather algorithmic approach at Michigan as we're going to our IRB. Whether or not this is research or QI, we go through that process. We don't ask we tell our hospitals, if you feel you need to for this work, you will. For our randomized trial, we absolutely did. Randomization is one of those things you check that box, like I'm randomizing, that's not a QI study anymore. But a large percentage of our observing what's happening, what we're learning, does fall under that QI bucket. So that's an overly simplistic answer. We use the framework that's been developed by our IRB for a lot of this. The payer also does have a little bit of a stake in this. Like, they fund our coordinating center, and they have not traditionally been excited about having hospitals not receive things that are potentially beneficial. That's their take on it. We say, we don't know whether they're beneficial. And wouldn't you rather invest in a rigorous evaluation of an approach you're paying a lot of money for to figure out whether it actually works? And so we've tried to look at things like step wedge designs, where you're not keeping anything from anybody, but you move it out in a phased, stepped approach, and you have concurrent controls that are essentially created by that methodology. So we've tried to be creative with our approach to evaluation to bring some rigor to QI work, but acknowledge some falls into that research bucket. Your other question about the governance and how you figure out what you work on, why 3, I oversimplified our approach to figuring out what we do. We have a big grid that we go through that lists a lot of different characteristics, a lot of different potential choices that we can work on. Our methodology, for the most part, limits us to a big initiative as opposed to hundreds, as you say, with the learning health system. For us to be focused, structured, abstract in a standard way, it's hard for us to do that in 100 different areas. So we have a big process by which we come to the conclusion we're going to work on PICC lines, or we're going to work on sepsis. And I didn't do it justice, but we also have, we do have governance for this. We have an executive steering committee, which includes those outside of our coordinating center, health services researchers, outside bodies. It includes the payer, our funder, that's part of that steering committee. And we use that body. We have a data design and publications committee that is basically, we're a collaborative, governed by a collaborative. We have representatives from all of our hospitals. Any project we're going to do, any publication, any use of our data, we have data use agreements with every one of our hospitals. We bring it to this group and say, are you okay with us submitting this abstract? I mean, it's a huge amount that goes to them. Like I didn't put like abstracts at meetings and like, it's just, they're getting peppered constantly with, here's what we're submitting, do you approve? And so we bring that forward to that data design. And so that's kind of the governance that helps us figure this out. They're also the ones that set the performance measures. Like, it's not me that sits there and says, here's how we're going to score your hospitals. We'll start with a proposal, and we have an algorithm for how we figure out what our thresholds are, what the cutoffs are. But we bring that forward to them. And we've had our hospitals push back. They said, absolutely not. Like, this is untenable. We can't do this. We can't do that. And so it's a bit of a collaborative work with them. But alignment with the hospitals is critically important. We learned early on, if you do something that the hospital's not that interested in, it's hard to get the resources, the buy-in. They're focused on a bunch of other things. So the more we can align with what their top priorities are, sepsis is a great example. Like, everyone's working on sepsis. They're like, yeah, that would be great. Like, we're fine with you working on that. That's critical for us picking our initiative. So long answer. I think I got most of your question.
Scott, we're at time, so I will say thank you and close it here. But thanks for a wonderful talk. And
All right.
hopefully people will ask you questions and walk up as well. Thanks so much, Dr.
Great.
Flanders.
Thank you.